Hey everyone, it's October, the start of spooky season, and there is nothing spookier than not staying up to date on code updates. So today I'm going to be covering the Icd-10-Cm updates for 2023, which go into effect, of course, October 1st of 2022. I'm going to cover for you the guideline updates as well as the codes themselves that have updated, short of anything that was like so minor that it's probably not worth noting. Sometimes there's these little minor editorial changes that don't really have much of an impact on code selection, so those we're going to skip over. In relation to the code updates, believe it or not, I got my Icd-10-Cm book a few weeks ago and have not yet opened it. I ordered the bundle directly from the AAPC pre-order a while ago, so my CPT book and my HCPCS book won't ship for a while, but I do have Icd-10-Cm. Here it is, and I heard tale that this is the year I finally get what I want on this AAPC edition. I can shake out all the snow. It's beginning to look a lot like Code Mess. So the word on the street is that this edition finally has the chapter-specific Icd-10-Cm updates at the beginning of the chapter. Drum roll. Chapter guidelines at the beginning of the chapter. Oh my God, I'm just so excited, so excited. So in the 2022 edition, they started with like some information about the endocrine system, but 2023, here we are, our chapter specific guidelines. Did they keep the accessory information? Yeah, so the other information's still in there. And of course, the full guidelines with all the different decision trees and stuff that the AAPC adds are still in the beginning. I thought I had heard a rumor at some point that the new updated guidelines were not printed in the 2023 book, that they still had the old 2022 guidelines, but that doesn't seem to be the case because these, I can see the bolded updates for 2023 for what's changed since the previous year. By the way, if you're new here, I'm Victoria Mull. I am a medical coder, auditor, educator, content creator, and on my channel, I provide lots of tips and tricks and tutorials to help you be successful in a medical coding career or give you some more information about medical coding. And I'm just going to say, if this particular video saved you some cash from having to purchase a very expensive webinar that you might not have needed, you can feel free to thank me with a super thanks and make a little donation to help support me and the channel. All right, but let's go ahead and get into these code updates. They go into effect, of course, October 1st of 2022, and I'm Victoria Mull with lots of credentials. So what has changed this year? We have 1,176 new codes, which sounds very overwhelming, but when you consider the fact that a lot of them are things that were expanded, and we have a lot of the initial subsequent sequela versions of them, we have a lot of different variations based off of laterality. It's actually not an overwhelming amount of updates that happened, but 1,176 new, 251 deleted, and then 36 were converted to parent codes. I always, of course, like to cover the guidelines first of all. So the first thing we're going to see in the guideline updates is, and I love this, a little update to 1A19, the code assignment and clinical criteria, how we assign the clinical criteria based off of the provider documentation. And what I found interesting here is that it specifically states now if there is conflicting medical record documentation to query the provider, which is something that we've always known in the medical coding industry, but it's really interesting now to see it in the official code assignment guidelines that it says, yeah, if there's something conflicting, you're supposed to query the provider. In documentation by clinicians other than the patient's provider, we had regulations stating that other providers might be able to document things like the patient's BMI, or we often see in the instance of like wound care, a wound care nurse might document the severity of the wound, or maybe a coma status, but now we're adding into that under immunization status. So this can be documented by someone other than the patient's provider. What it does say, though, is that the under immunization status should only be reported as a secondary diagnosis. Same with the BMI, same with the coma scales, etc. And just as a reminder with the BMI, those coordinating diagnoses, though, have to be documented by the provider. Just the fact that the BMI is documented by someone as being 40 doesn't mean that we can assign the code for morbid obesity. The provider has to be the one specifically to diagnose that patient with morbid obesity. We've seen some clarifications here in regards to complications of care. So it says there must be a cause and effect relationship between the care provided and the condition, and the documentation has to support that the condition is clinically significant. It is not necessary for the provider to explicitly document the term complication. For example, if a condition alters the course of surgery as documented in the operative report, then it would be appropriate to report a complication code. Now, it also says to query the provider if the documentation isn't clear as to if there is a relationship between, oh, this patient had this thing that looks like a complication, and was it a result of that procedure? A change to HIV-related conditions. So when a patient has an HIV-related condition, that principal diagnosis has to be that B20. Now, there's one exception to the guideline, and that is if the reason for the admission is hemolytic uremic syndrome associated with HIV. In that case, we're going to assign D5931 as our primary diagnosis and then B20 as a secondary diagnosis. And then just kind of to further clarify here, there was a small change made where they changed it from, I think, just saying HIV-related illness or AIDS, or maybe it just said HIV disease, and now they are clarifying HIV-related illness or AIDS to include in this documentation guideline. This one, of course, kind of carrying on from the HIV, if the reason for the admission is hemolytic uremic syndrome, we're going to assign the D59.31 as that principal diagnosis. Encounter for treatment of the primary site. So this is for our chapter 2, which is our codes for different neoplasms. So if the malignancy is chiefly responsible for occasioning the patient admission or encounter, and treatment is directed at the primary site, that primary malignancy is going to be our principal or first listed diagnosis. And then the only exception to that is if the patient is receiving administration of chemotherapy, immunotherapy, or external beam radiation, and that's the reason for the encounter is the chemo, the radiation, etc. We're going to assign Z51 category codes first as that principal diagnosis. And let me just kind of backtrack a little bit. When we say principal diagnosis in the guidelines versus first listed diagnosis, I've seen a lot of people get confused about what that means. A principal diagnosis is when we are billing on the UB04. We are billing for hospital services. That principal service is on the UB04 form for the facility services. When we say first listed diagnosis, we're talking about that first diagnosis code on the CMS 1500 form for provider-based services. They're not interchangeable. We're talking about two different types of coding. Basically Part A or Part B for Medicare. Are we billing on the UB04? That's principal diagnosis. Are we billing on the CMS 1500 form? That's first listed diagnosis. Getting back to our slides. Secondary malignant neoplasm of lymphoid tissue. So when a malignant neoplasm of lymphoid tissue metastasizes beyond the lymph nodes, we assign a code from category C81 through C85 with a final character of 9 that should be assigning the extranodal and solid organ sites rather than assigning a code from secondary malignant neoplasm of the affected solid organ. And so it gives us an example here. So it says, for example, metastasis of a B-cell lymphoma of the lung, brain, and left adrenal gland, we're going to assign code C83.39, we have that last character of 9, for diffuse large B-cell lymphoma, extranodal and solid organ sites. A couple of just small changes in the diabetes guideline. They kind of clarified now with the hypoglycemic drugs versus the anti-diabetic, and the injectable versus the non-injectable drugs. And then, of course, that follows along with our secondary diabetes guidelines, same concept. And dementia. So now the severity of the dementia is going to be dependent on the provider's documentation of severity. We're going to see some of those new dementia codes that have been developed. So if the documentation doesn't specify, we're going to use the unspecified severity code. So that's going to be a point where providers can probably use some education about these new codes that have been developed to better track the severity of these patients who have dementia. Are they having mild, are they moderate or severe types of dementia? So something for them to start including for those tracking purposes. In the case of an inpatient stay, it also states that if we're billing for inpatient facility services, remember, inpatient facility, UBO4, and the severity changes, like maybe they started out moderate and then by the time the admission ended, they were severe, we're going to code for the highest severity level that's reported during that stay. And this guideline, I think, is a good one to add in, but basically it says that you can't round up your weeks of gestation. So if a patient, for example, is at 39 weeks and 6 days, they have not completed 40 weeks of gestation. So even though it's close to 40 weeks gestation, we're not going to round up the weeks to 40 weeks of gestation. And we have here hemorrhage following an elective abortion. So for hemorrhage post-elective abortion, we assign code 004.6, delayed or excessive hemorrhage following an induced termination of pregnancy. We don't assign the code 072.1, which is other immediate postpartum hemorrhage. And that's not to be assigned for those post-abortion conditions. And we also don't assign Z33.2, encounter for elective termination of pregnancy, when the patient is experiencing a complication post the elective abortion. We're supposed to be using that delayed excessive hemorrhage code. Documentation of a change in the patient's condition is not required in order to assign the underdosing code. However, the documentation that the patient is taking less of a medication that is prescribed, or the discontinuation of the prescribed medication is sufficient for code assignment. It doesn't specifically have to say the term underdosing. So this one was actually a small change in the title. You can see here now it says just basically that Z codes indicate a reason for an encounter, or they also provide additional information about a patient encounter. So now it's not just saying it's necessarily the reason. It could just be providing additional information, which I think is an important concept to clarify. Something that we all kind of knew, but not nice to see it coordinating with what's in the guidelines. Pediatric to adult transition counseling. So we'll see some new codes for that as we go along too. And that should be assigned when pediatric to adult transition counseling is the sole reason for the encounter, or when the counseling is provided in addition to other services, such as that pediatric patient is being managed for different chronic conditions. So if both transition counseling and treatment of a medical condition is provided during the same encounter, so the patient's coming in because they have, chronic diabetes, and they are also going to be transitioning into, an adult setting where they're not going to see a pediatrician anymore. They're going to see an adult family medicine doctor or an internal medicine doctor. So if they're having that chronic condition discussion and also discussing, hey, you're going to have to be transitioning into like an internal med setting, not just pediatrics, we assign code Z71.87, and the sequencing really depends on the circumstances of the encounter. Social determinants of health, very popular these days, super, super popular. Codes describing the problems or risk factors related to social determinants of health have to be assigned when they impact the services or that encounter for that day. So we're not just going to go, oh, well, this says this patient is homeless. We're going to assign that code. It has to impact their care somehow. And we can assign as many of the SDOH codes as needed, but they have to impact some sort of treatment plan or their ability to receive healthcare services for some reason. For example, not every individual living alone is going to be assigned code Z60.2, problems related to living alone. It has to impact their care somehow. Like, are they at maybe a seizure risk, and it's complicated that they're living alone because if they have a seizure, no one will be there to help them, And now let's get into our new code. So we're going to go down through by chapter to chapter to chapter, starting with chapter 1 through chapter 22. Chapter 22 didn't have any updates. but we're going to start with chapter 1. And I apologize, the slides are going to be a little bit small, some of the print on them, because I didn't want to blow some of them up and then some of them be a little bit cramped in. But in any case, I'm going to include these slides on here so that you can download them. If you want to give this presentation at a chapter or wherever to your providers, feel free. The only thing I ask you guys is that you please not download the slides and then make your own webinar and then sell it, because I don't like people profiting off of something that I'm trying to be nice and give away for free. Anyway, so we have 2 new codes that were developed to identify different types of yeast infections. So most women, like 75% of women, will have at least one yeast infection in their lifetime. Most of them are mild or moderate. Now, Icd-10-Cm is going to break down between the acute or chronic candidiasis of the vulva and the vagina. So an episode of uncomplicated vulvovaginal candidiasis is often considered a nuisance, but it's easily resolved. However, if you've got something that's recurrent, it's chronic, those patients typically endure like multiple relapses and they require more months of treatment. Prior to that, we just had this being a 4-digit code, B37.3. So now you have to expand upon that with that 5th character, because that 4th character one is no longer a valid code. We need to have the full extension. Neoplasms, chapter 2. So we have 2 codes: peripheral T-cell lymphoma, not elsewhere classified, extranodal and solid organs, and then myelodysplastic disease. And then we had some revisions here, just of some of the terminology used in the peripheral T-cell lymphoma coding revision verbiage. When we look at our chapter 3 codes, so D59.3 was expanded and now it's going to need a 5th character. So hemolytic uremic syndrome, or HUS, it most often occurs with a GI infection like an E. coli. And this is called typical HUS. However, the condition has also been linked to other GI disorders, including Shigella and Salmonella. So there are instructions there to use those additional codes or code first any other incorporated diseases. So pay close attention to some of those instructions that they give you with those codes. Von Willebrand is expanded to delineate now between the different types and the severities of this clotting disorder. And then we have heparin-induced thrombocytopenia, and that's a decrease in platelet count, and it occurs during or shortly after exposure to heparin. And with the wide usage of heparin for treating or preventing blood clots, this is a fairly common problem, which can be serious and it can be life-threatening. So this was added and differentiates now between the immune versus non-immune, and then the other and unspecified codes. So here we have some codes surrounding stature. Okay, so changes in normal growth patterns, they may be a sign of a pathological condition. So physicians monitor the linear as well as the skeletal growth from birth through adolescence, and then the treatment and investigation differs depending on that nature of the short stature. So the codes were adapted as they break down further than just endocrine disorder, which was what we previously had. And then we have some new codes here for acidosis, and that was expanded to differentiate the unspecified, the acute, the chronic, and then the other. And then chronic metabolic acidosis, which is a complication of chronic kidney disease, is also associated with an increased risk of progression or death by that CKD. So it's really important to differentiate those for tracking those patients. And we talked a little bit about these dementia codes. So here we're seeing that. You saw in the guidelines, they're now expanded on in the severities. So we have an unspecified, we have a mild, we have a moderate, we have a severe, and we have in diseases classified elsewhere. And then within each of those, we have with or without behavioral disturbances or agitation or mood disturbance, anxiety, psychotic disturbances, etc. And here we have the vascular dementia codes and then the non-vascular dementia codes. And then here we have the in diseases classified elsewhere variations. continuing to the unspecified, and then we get to our F0670, we have these mild neurocognitive disorder due to known physiological condition without behavioral disturbance or with behavioral disturbance. There is a range of cognitive impairment that is related to aging, from the normal changes that come with getting older to more serious deficits. In the past 15 years, there has been increasing interest in mild cognitive impairment related to neurodegenerative diseases other than Alzheimer's disease and in other diseases as well. And then after that, we had this like small change to our alcohol use, our opioid use, cannabis use, etc. in remission, and that were unspecified. So for example, we used to have code F16.91 for hallucinogen use, unspecified in remission, but you can see now here that it has expanded the code and the description to include the words in remission. Prolonged grief disorder and other reactions to severe stress were added to Chapter 5 as well. So prolonged grief is characterized by intense, prolonged symptoms of grief coupled with clinically significant functional impairment that persists beyond 12 months following the loss. So 12 months plus would be considered prolonged grief. As we get into our Chapter 6 codes, we have some additions here in Chapter 6 for limb girdle muscular dystrophy, and that has expanded to include autosomal and the dystrophy due to other causes outlined here in this slide. Postural orthostatic tachycardia syndrome, or POTS, is a chronic autonomic nervous system. We also have our G9 3.31, which is our post-viral fatigue, G9 3.32, myalgic encephalomyelitis, chronic fatigue syndrome, and then G9 3.39, which is other post-infection and related fatigue syndromes disorders that can cause severe disability and impairment in quality of life. POTS is estimated to affect as many as 500,000 to 3 million people in the US. And though we haven't had a lot of precise epidemiological studies conducted to date. Chapter 7 and 8 were no changes this year. Chapter 9, diseases of the circulatory system. So we have refractory angina pectoris. Refractory angina is a condition where a person has chest pain that lasts for more than 3 months and cannot be controlled with medication, with surgery, or stents. So we created additional new codes in the atherosclerosis of coronary artery bypass grafts and coronary artery of transplanted heart with angina pectoris subcategory. And then we have malignant pericardial effusions and diseases classified elsewhere. So malignant pericardial effusions, they're a specific type of pericardial effusions related to cancer. This type of effusion can be caused by the cancer spreading to the heart or the pericardium, which is that membrane around the heart. And it also can be caused by radiation therapy, an infection, or toxicity from chemotherapy drugs. So malignant pericardial effusions is I31.31, and then the 39 is the non-rheumatic and other non-rheumatic expansions. We have subcategory I47.2 has expanded. So we have 20 is ventricular tachycardia, 21 is torsades de pointes, and then 29 is other ventricular tachycardia. So torsades de pointes is a specific type of ventricular tachycardia, which is a fast heart rhythm. And you can get it if you inherited long QT syndrome or if you take certain medications. And if you don't treat it, it can be deadly, but with treatment, it's a pretty good outlook. And then I71.0 expanded for dissection of ascending aorta, aortic arch, descending thoracic aorta, and thoracic aorta unspecified. And then we can see here there's a lot of codes that were added to those aortic aneurysms. They break down by ruptured or without rupture and unspecified, and then a lot of different ones based off of the location, and then again further differentiated by the rupture status. Chapter 10, we had one code added for Chapter 10, TAD, transfusion associated dyspnea, dyspnea. The introduction of a condition-specific code for TAD will greatly improve the coding accuracy and increase provider awareness of this potentially serious transfusion-related adverse effect, and will allow us to kind of better understand the pathophysiological reasons, enhance our monitoring of it, and understand kind of the risk factors involved. So it's going to be really helpful in the development and evaluation of prevention as well as treatment strategies, right? So this code distinguishes between our current codes for TACO, which is transfusion-associated circulatory overload, and TRAILI, which is the transfusion-related acute lung injury. Chapter 11, K76, other specified liver disease, has expanded now. So we have K7682, which is hepatic encephalopathy. And then acute appendicitis, revised the codes for with perforation, localized peritonitis, and gangrene with or without abscess. No changes to our Chapter 12 codes for diseases of the skin and subcutaneous tissue. Not a lot of exciting things going on with skin this year, I guess. Lots of stuff added, though, for our musculoskeletal system. How about that? So there are a lot of new codes added to the musculoskeletal section this year. We have M54.A, which is for intervertebral annulus fibrous defect. And then we have the lumbar and lumbar sacral region, and each of those break down by unspecified size, small or large. There's no medium. And following that, we see muscle wasting and atrophy not elsewhere classified. That's broken down by cervical, thoracic, lumbosacral, or unspecified. And then we've expanded onto some codes for slipped upper femoral ephysis of the hips. And then we continue with the femoral ephysis broken down by acute or acute on chronic, as well as the different lateralities. And M96.A is a new subcategory for fractures of the ribs, sternums, and thorax, and that's associated specifically with CPR. So there's been some coding clinics in the past stating that, a patient can fracture a rib if they're administered CPR, but we shouldn't code that as though the patient just had an injury or an accident and fractured their ribs. So now we're going to specifically differentiate, this patient was administered CPR and there was a risk of fracturing the ribs or sternum. And, that's going to be differentiated between, the patient was in a motor vehicle accident and fractured their ribs and sternum. Now, moving on to our Chapter 14, diseases of the genitourinary system, we have N1411, which is contrast-induced nephropathy, versus our nephropathy that's induced by drugs, medicaments, or biological substances. Previously, we had mucositis of the vagina and vulva, and now we have further expanded this to include diseases of the vagina and vulva, which are Fourner's disease. And then we have a lot of expansion of category N80, our endometriosis codes. So we have different indications now as far as things like which ovary is involved and whether it is superficial or deep. And this can better track instances of the specificity that's related with this disease. And here you can see the location also continues to involve the fallopian tubes, and the interior cul-de-sac as well. And then we go on to the pelvic sidewall, the pelvic brim, peritoneum, ureterosacral ligament, and of course here's all the breakdown by laterality and the depth involved as well. And then we have the unspecified codes. And then we expand endometriosis codes if they are involving the intestine, the rectum, the colon, the cecum, the appendix, and then other parts of the colon, small intestine, bladder, and ureter. The pleural, the lung, diaphragm, and then we start getting into things like pericardial space, cardiothoracic spine, abdomen. Abdomen breaks down between the different layers of tissue of the abdominal wall. Then we have the umbilicus, the inguinal canal, extrapelvic, abdominal peritoneum, other sides of the abdomen, as well as the pelvic nerves. And then you can see here, these ones that are more specific to the location don't break down like the bilaterality that we saw on the ovaries and stuff. They're just for the specific nerves involved. And then lastly, in chapter 14, we have an isthmocele. And that term is also known as a Cesarean scar defect. And it basically describes a hole at the incision site of a previous Cesarean section. And the isthmocele can complicate surgery in many ways. It may cause abdominal placentation. It could cause interstitial pregnancy, Cesarean scar dehiscence, and uterine rupture. And there was a code for this in pregnant patients, an O code, but now we have this N code that's for patients who are currently not pregnant. Very large expansion in maternal care and suspected fetal anomalies. Here you can see the ones that are for maternal care for suspected central nervous system malformations or damage in fetus. And they are broken down by the number of fetus. And they just continue based off of specifications and the number of fetuses involved, continuation, further continuation. And then after we get towards the end here of this slide, you can kind of see that we are looking at chromosomal anomalies that are suspected, such as trisomy 13, 18, 21, Turner syndrome, sex chromosome abnormalities, other chromosomal abnormalities, fetal facial anomalies, cardiac anomalies, pulmonary anomalies, GI anomalies, GU anomalies, musculoskeletal, fetal upper extremity anomalies, lower extremity, central nervous system malformation, and chromosomal abnormalities. And, this year, there's certainly been a lot of attention garnered to pregnancies and situations surrounding pregnancies. So hence there is a lot of expansion in the care surrounding them. As a result of the complex issues facing neonates, particularly those who are premature, the American Academy of Pediatrics requested that we have some ICD-10 codes added specific to sleep apnea and then the apnea that occurs outside of sleep. So we've added more codes for different congenital abnormalities to better track the data and assist with the specialized training and assessments of those particular anomalies. Chapter 18, no changes. Chapter 19, we usually see a good amount of codes for Chapter 19. Pretty standard. There's usually some new type of specification of injuries and external causes that need to be expanded or clarified. So a lot of the codes here were expanded to include a loss of consciousness. Those that already had in the text the loss of consciousness of 30 minutes, these have been expanded out a lot more, where there's more specific ranges of time than the previous codes that we had here. So pay close attention if you use these codes, that now these time ranges have changed with the status of how long there has been a loss of consciousness. And then we had some additional poisoning codes in regards to the use of methamphetamines. Chapter 20 was greatly expanded again, typical of ICD-10-Cm changes. So there was some more specification we wanted surrounding accidents in regards to bicycle collisions and e-bicycle collisions, so electric bicycle collisions. So basically anything that could collide with an e-bicycle, they had to provide some code adaptions surrounding that. So there's the different code sets for anything that e-bike could collide with. If they're colliding with another pedestrian, if they're colliding with another bicycle, if they're colliding with a car. And, this is a differentiation that's made because of the different regulations as far as e-bicycles. So they want to track things because there are regional differences as far as speed limits, as far as the different safety precautions taken surrounding these. So they want to kind of make sure that they're keeping track of the accidents and outcomes specific to those. So basically every subcategory has been further expanded for what type of vehicle may have been involved into an accident with a e-bicycle collision. And following that, we have one additional code that was added to the W codes for if you were caught, crushed, jammed, or pinched between an object that's moving and one that is stationary, right? So not two moving objects, not two stationary objects. You're crushed between one's moving and one is stationary. Now, we talked a little bit about some of those social determinants of health codes that were changed. And in the social determinants of health, remember that these are reported only if they impact treatment for that day. So we have here like transportation insecurity. So that's things like if they have inadequate transportation, they have a lack of transportation, they have an excessive transportation time, maybe because they have a high volume of traffic in their area, or even things like unsafe transportation. They have an unsafe transportation method. So again, if that impacts them being able to receive treatment, maybe they can't get to a place where they need to go for some sort of medical service, then that would be a code that we would want to report. Financial insecurity, that could be things like having a lot of debt, filing for bankruptcy, they're unable to afford all their bills or make ends meet. But there is an excludes to note here, which says that it's excluding extreme poverty or low income or other material hardship not classified elsewhere. And then material hardship, if you think material things. So inability to obtain things like clothing or things like childcare or utilities. So maybe they can't afford running water or other basic needs. So then we have that code for pediatric to adult transition counseling. So you should be using that if that is specifically what that patient's getting and not use the other unspecified counseling type of codes. Then we have encounter for counseling for socioeconomic factors. And we also added Z7 2.82. Remember we talked about there was a big expansion about all these pediatric anomalies. Well, they also want to track things like if a patient's at risk of apnea or suffocation or smothering while they're sleeping, which is typically due to co-sleeping with an adult. And then there's been an expansion to the long-term use of different drug therapies, such as immunomodulators and anti-tumor antibiotics. And then here we see more long-term use as well as personal history codes for different conditions. And following that, we have patient non-compliance with dietary regimen, and it specifies if it is due to financial hardship or other reason. So if they're not being compliant with their diet, and also we have here underneath that the medical treatments, if it is due to a financial hardship, maybe they can't afford the right dietary items that they need to purchase or medical treatments. So that's non-compliance because they can't afford it, versus not because they can't afford it. And in addition to that, interestingly enough, we've added some codes for if the patient is non-compliant, not because they personally aren't doing it, because they are in the responsibility of a caregiver, and that caregiver is being non-compliant, or that caregiver is intentionally underdosing the patient's medication or not giving the medication for whatever particular reasons. And then no changes to Chapter 22, which is our codes for special purposes. So that's it for ICD-10-CM changes for 2023. If you have any questions, definitely let me know in the comments below. By the way, if you need more updates, don't forget to like, share, and subscribe. I will see you guys in the next video. And until then, just keep on coding on.